So what's our existing knowledge? Well, we like to think we know more than we do. And in order to try and expand how we evolve care for PSC, we need to take a step back and say, look, actually, hold on, put on the brakes. Let's actually sort of break things down to their raw principles and find out how does PSC and IBD interact with each other? Is PSC without IBD really a thing? Should we be looking harder? And when somebody with IBD is diagnosed with PSC, what does it actually mean for them? So I've put this here saying, keep calm, life begins at 40. And that's because I turned 40 this year. And the other reason I put it there is because 40 is actually the average age at which most people are diagnosed with their PSC. Now, this is some data from our colleagues in the Netherlands, and it's a bit of a busy graph, but I'll talk you through it. What this graph shows is the incidence. Though this is an estimate, so for every 1,000 individuals, how many people develop bowel cancer. So the light grey shows people with PSC according to the age, which is on the x-axis. The general population is the dark grey bars, and again, age is on the x-axis. And what you can see is that for every 1,000 individuals who've got PSC, it's younger people, so those people diagnosed particularly below the age of 40, who have a much, much higher risk of developing bowel cancer compared to their age-matched counterparts in the general population. Now, I'm not putting this up there to scare anybody, but I'm sure it will scare some people, and I apologize for that. But this is to highlight that the reason we push for surveying you, push to do colonoscopy every year, is particularly when you're young, is because of this particular graph. Yes, we know that the risk of cancer does become greater and greater in the general population the older you are. But in PSC, that risk begins at a much earlier age. So I do plea that if those individuals who think that cancer doesn't affect them because they're young, please continue with your colonoscopy. Most of you will never get it, but it's very important just to to continue with your colonoscopy. So if we see lesions that are early stage, we can treat them so you never get cancer. But to try and identify sort of risk factors, the incidence side, the new development of other complications between people with PSC who have IBD versus those who have IBD alone, the UK is in a really powerful position because of our National Health Service and the way that digital data can be mined. So this is just an example from a recent study that we completed, looking across the whole of England, because we can access data in Birmingham from across the whole of England. We're looking at the devolved nations as well, but at the moment, sort of our access restrictions are for England only. And what we did over a 10-year period from 2006 to 2016 is looked at everybody with inflammatory bowel disease and also those people with inflammatory bowel disease who developed PSC. Now, it's not to say that those of you without inflammatory bowel disease don't matter. That's not what I'm saying at all. It's just that at the moment, because PSC is so rare and because diagnosis is sometimes difficult in those centres that see only a few people with PSC, those people with PSC and IBD are often diagnosed more confidently and more quickly. And that's why sort of this particular study was conducted in this way. And the second reason is we wanted to see, does developing PSC differ compared to having IBD alone? Now, the first thing to say is that whilst PSC and IBD are related to one another, the areas of England where most of the inflammatory bowel disease is diagnosed, that's the darker shades of blue here, differ to the areas where PSC is diagnosed the most, which are the darker shades of sort of pink purple here. When you move to the right-hand side of the slide and look at these lines, the top line, if we just focus here, is all cases of inflammatory bowel disease, new cases of inflammatory bowel disease that develop over time from 2006 to 16. And the line is relatively flat for all inflammatory bowel disease. For ulcerative colitis, maybe there is a slight increase. For those people with Crohn's, and for those people who've got what we call an indeterminate phenotype, a phenotype that is somewhere in between Crohn's and ulcerative colitis. But you can see that actually those cases of PSC and inflammatory bowel disease are rising Now, clearly the scale is different, but you can see that the cases are rising much more compared to those people with inflammatory bowel disease alone. Now, it could be that we're better at diagnosing it. Some of you will disagree with that, I'm sure, but it just goes to show that there must be something either in the air, in the water, in the soil that is causing an increased incidence of PSC, particularly in the northern parts of England. The second thing is, let's talk about risk. Now, when you get diagnosed with PSC, you're giving a wealth of information. And not only are you giving a wealth of information, you're scared because you're told about all the bad things that may happen. When we looked across the whole of England, what we see is that the younger people, things like liver transplantation or sadly death from PSC, make up most of the bad things that we see in that group. Why am I highlighting that? Well, when I see somebody who's diagnosed particularly below the age of 50, below the age of 60 years old, the reason I'm so adamant to put this individual into a clinical trial, it's got nothing to do with my own sort of gain from it. I gain nothing from doing so. But it's because I have to get you through significantly greater life years from your current liver because of this graph. Those people who are diagnosed in older age, it's much more likely that they'll fall into the red group, where non-PSC related problems will rear their head. And that's why perhaps when it comes to individuals diagnosed in older age, whilst they have a risk of developing complications from their PSC, it's relatively lower compared to those people of younger age, which is why my approach is slightly different. And it may reassure some of you, whereas others, I may sort of be a bit more fearful. The other thing that people get frightened of course, is bile duct cancer, cholangiocarcinoma. Now, sadly, this is still an incurable cancer in the current day and age. Some parts of the world do offer liver transplantation with very mixed results. The reason it's quite difficult to survey and to identify confidently who's going to develop these is because most people who develop cancer, so these are all cases of bile duct cancer across the world, across a 30 to 40 year period in a patient cohort of about 7,000 individuals. When we looked at all the cases of bile duct cancer, most of them occurred in the first 1 to 2 years of being diagnosed with PSC. So the person that frightens me is the person who's diagnosed with PSC, and then that individual becomes jaundiced within the first 1 to 2 years, because that's the group of individuals where I see most cases of cholangiocarcinoma. As time goes on, however, the rates of cholangiocarcinoma gets less and less. And I sort of will be provocative enough to say, the longer you're diagnosed with your PSC, the less likely it is that I'm going to identify a cholangiocarcinoma. Doesn't mean I'm not going to look for it, but my fear gets lower and lower with each year. Now, I know many individuals, Martini in particular, does not like these sorts of survival curves, and this is one of the very few that I'll put in here. Now, let's just focus on the graph on the left. One of the other things we've been able to do in the UK, and this has been also shown in North America now, is around surveillance. So when you have PSC, we put you through a wealth of different types of scans. And every year, it is my belief, and I'm sure Simon will share this opinion, that you should have a scan of your liver and bile ducts, either an ultrasound every year, or at least an ultrasound every year with an MRI every 2 to 3 years. Now, that's what we would call surveillance practice. That's a mode of surveillance. And what we see in the UK is in the people who develop cancer, who have had scans performed every year, this is the blue line, their survival after the cancer is diagnosed is much better compared to those people who did not undergo surveillance. Now, what is this survival from, and what cancer am I talking about? So I'm talking about all types of cancer that affect the liver and bile ducts: cholangiocarcinoma, gallbladder cancer, liver cancer, pancreatic cancer. What we see is about a twofold better survival in people who've got cancer in those people who were surveyed. Why? Because we pick up cancers at an earlier stage if we're scanning you every year. When it comes to cholangiocarcinoma, though, bile duct cancer, the lines cross over. Sadly, because most cancers occur very close to the point of PSC diagnosis, annual scanning does not necessarily impact outcomes. There is some data in the US, which I'm sure people will touch upon in the question and answer, about whether they should have an MRI scan every year or an ultrasound, and that's a topic of much debate, and we can take that and we can talk about that later.